Good evening, everyone, and a very, very warm welcome to yet another episode of Safe. And thank you so much for many of you for being here ahead of time. And as promised, we start exactly at 7, and we hope to wrap up by 8 or maximum by 8:15. So stay tuned. And before I hand it over to Karishma, I have few things to share and then we will start. And this time, we are also going to play the Annie anthem before we get into the session. So I would request those who can, please, you can put off the video and stand in respect to the anthem. So safety awareness for excellence, that is the full form of safe learning sessions are hosted by Annie's Patient Safety Fellows. And this is the fourth cohort that is running now. The fifth cohort, we will be asking for applications very soon. So let us start with the.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
I really hope those who have not heard the anthem, you have heard. For me, it's a very heart-touching, song, and almost everyone had opined on that. For every life, we fight the fight. I think the safe sessions are also to equip, impart knowledge, discuss, to see that how we can protect our patients' lives, those who are interested to us, right? That is what we are all in this profession, and that's what I that we all are wanting to do. So, with that anthem, so let me take you quickly through few slides before I invite Karishma. So this Patient Safety Fellowship Program is, held in collaboration with Patient Safety Movement Foundation in USA, and they have very kindly supported this initiative. And Dr. Mike Ramsey, who is the CEO of the for the Patient Safety Movement Foundation, he always makes it a point to know what our fellows are doing, and he is always present every year to look at the project that is being presented by our fellows. So as you all know, we do have a yearly calendar, and so far we are on time. And so July is the one that we are hosting now, and then we have the 4 months to go by. And today the session is being presented by Karishma, and she's ANEI Patient Safety Fellow of 23-24. This year she will be graduating, and next year during ANECON they actually go through a convocation ceremony as well. So she's going to talk about how to identify, reduce, and prevent hypoglycemia in admitted patients. So there are a lot of literature that's coming out that this is a problematic area not only in India, across the globe. So there had been sentinel events related to hypoglycemia. So we will hear more about it from Karishma. And just a quick word. If you have not yet registered, you're all welcome to Guwahati, AIMS Guwahati, on 19th of September for our annual ANI Patient Safety Conference. So that creative has been already released, and in August we would have Miss Margaret who will be talking about reducing alarm fatigue. That is going to happen, and 2024-26 fellow. So this creative has already been released, and so please go ahead. Those who are from the state, obviously we expect all of you to register in numbers, and those who are outside nearby states, we hope that you will join us. And anybody from across India is welcome to join us. And do watch out for exciting pre-conference activities, like there are pre-conference workshops happening. That is mostly for the local in Guwahati and nearby nurses. But definitely we have competitions where the three finalists can reach Guwahati to present your quality improvement project or research paper or your post presentation. One of the competition details had been released, the rest will be released tonight. So watch out in the social media, and we hope that all of you will join us in large numbers and you will be with us in Guwahati, where we focus one full day on patient safety. And this year's theme, I'm sure that all of you are aware, it is around pediatric neonatal safety. That means safety from the start, safe care for every newborn and every child. So we are making our effort to see that the people who are experienced in this domain are taking part in the deliberations in that one day agenda. So we hope that you all will contribute and participate in the competitions. And thank you. So I stop there, and now I hand it over to Karishma. Over to you. All the best. And the team who are here, in case you have questions, please put them in the chat box. Usually we don't take questions in the middle. Once Karishma finishes, we can take some questions and discuss on the issues. And I would request all of you to please keep your audio video muted because that will Oppo is not yet muted, so I'm muting. So please make sure that you stay muted so that we can
So that
you can we can hear the
we can
speaker very well.
speak very well.
Karishma, I'll
Thank you
be
so
off audio, off video, and I'll come in only if required. And if you need my help, just call out. Okay.
sure, ma'am.
Thank you.
Thank you so much, ma'am, for giving me this opportunity. Good evening, everyone, and thank you so much for joining for this learning session. I hope after finishing this session, we are going to have lots of learning and take-home messages, which we can implement in our day-to-day, like work life. So this is safety awareness for excellence, and my topic for today is identify, reduce, prevent hypoglycemia in admitted patients. Ma'am has already introduced. Still, I'm a very, very proud ANEI Patient Safety Fellow member from 2023 to 2025. From for this Patient Safety Foundation USA, we have done this project, and I am very, very happy to present in front of all of you today. To introduce my topic, we all know as a healthcare team members that hypoglycemia or severe hypoglycemia in hospital settings might be experienced by many patients, even if patient is having diabetes or not. So while hypoglycemia is associated with increased mortality, in many cases, it is rather it is the underlying disease rather than a cause of fatality. So it is very, very important to identify the early warning signs and the signs and symptoms of hypoglycemia so that recurrent hypoglycemia will not occur. And as ma'am already mentioned, there might be sentinel events because of this hypoglycemia. So it is very, very important to understand and how to prevent this hypoglycemia in admitted patients. So many episodes are actually preventable. It is in the hand of healthcare providers. So there should be a protocol which should be adopted by each hospital systems and which can prevent and identify. It is going to be very, very easy to identify the hypoglycemia in the hospital system. So with this concept and the importance of hypoglycemia related events, we have taken a project title is equality improvement projects to identify events of hypoglycemia in order to preventing adverse events through a standardized protocol. So this was our title. Why we have taken this project is hypoglycemia is a serious patient safety concern as it leads to mortality as well as morbidity. And we have seen that nursing community, we face various issues to clinically manage the patient whenever hypoglycemia events occurs if there is no any standardized protocol. And also we have analyzed the hypoglycemia events. The number was quite surprising and it was 38 number from October 2023 to April 2024. We have also identified there were missed dose of anti-diabetic medication for preoperative patients because of lack of knowledge or because of many other factors. It was also identified that correct diet were not modified in a hospital information system because of which diabetic patients were, lack of this diet management. It was also noted that knowledge on prevention and management of hypoglycemia among healthcare providers are utmost important, and lack of in-depth knowledge will lead to some problem. So, with these all reasons and background, we have taken this project with our team and project team. And being a patient safety fellow, I was a champion and my chief nursing officer was a project leader. I had a very proud mentor, Dr. Vijaya Thangam ma'am, and my team member were these were the charge nurses from my hospital. So this is the team we have created. We have done brainstorming and we have identified to go ahead with four objectives. First objective was to identify the events of hypoglycemia. Second one was to assess the compliance of blood sugar monitoring. Third one is to develop and implement a standardized hypoglycemia prevention and management protocol. And last one was assess the number of hypoglycemia and way of managing post implementation. With these objectives, we have taken the methodology of PDCSR cycle, where we have formulated the team, as I have already mentioned. We have also planned to identify the hypoglycemic events, the numbers. The data collection tool was developed. Leadership team was also involved. The issues were raised in drug and therapeutic committee meeting and quality safety meeting as well.
detailed discussion with HOD of laboratory so that we can do point of care testing meter quality check. These all were in our planning phase. In do, audit process were carried out, sensitization of staff through training, classroom training both, and on the job training. Diabetic certification course was also planned. Creation and implementation of hypoglycemia algorithm was done. Modification of insulin sliding scale, customization of food tray and types of insulin. So these all were in our mind. And we have checked continuous monitoring and process check for blood sugar monitoring compliance. There was a custodian for this specific audit. Process check was carried out in bedside, reviewing all code yellow cases, the reason for this, and we could identify a few hypoglycemia events. Knowledge check of staff nurses were also done. And next, continuous audit process in service education and reward and recognition, which is still going on. Before implementing the protocol, we have find these compliances rate which were not very good compliances. Like to tell few examples, documentation on independent double check was only 43%. Compliance on TAT between the administration and the food administration was also very low. Awareness on category of insulins, which type of insulin among the nurses were also very low, that is 38%. So we have created a diabetic course module and we have started to train the diabetic certification course, and also we have proceed for POCT quality check with zero billing. These all are the activity done. And we have started staff training on hypoglycemia management. This algorithm was created. Diabetic certification course we have brought out and selected few staffs and to start the training, and it was a detailed training for full day and certification was given. Hypoglycemia management algorithm was prepared. It was also approved from the TC committee, and we have displayed in all the inpatient areas so that it became very easy reference for nurses to manage the patient whenever hypoglycemia events happen. We have also displayed the types of insulin chart near and above the fridge. This was added in nursing empowerment policy for treating hypoglycemia. And glucon D packet was added in all the impress stock after approval from DTC committee, which was not there earlier. These are the few glimpses of training which we have conducted. Along with the training, we have also taken the chance of World Diabetes Day, where we could also train the patient and family. And this was post my project, which we have done. Even during the last year Nurses Day celebration, we have taken this out because this is very, very important as patient has to know and patient and family has to know what all are their early signs for identifying hypoglycemia. We have gone to community and we have started checking and telling them the what all are the signs, when to meet a doctor, all those points we have done. We have done. After implementation, this is the improvement which we have achieved. Every compliances were satisfactory, and also there were knowledge check, especially on awareness on category of insulin, which got improved. Although it was checked that time, still because nurses attrition is very, very like common, so we have to continue this training program for nursing, like a diabetic certification course which we are doing. Hypoglycemia events and management of events, if we looked into, number of hypoglycemia pre-implementation of the standardized protocol was 38. Post-implementation, it was only 38. Post-implementation, it got reduced to 8. And previously, we directly go for 25% dextrose, or like we don't identify because there was no availability of glucon D. So uses of glucon D became 100% whenever nurses find signs of hypoglycemia. Way forward, we thought of continuing the audit to identify if any deviation and improve the process, which we are still doing. This is a monthly high risk process initiative. Continuous in service education. This is also added in nursing induction training whenever they first join. We also had a plan to complete diabetic certification course for 100% nurses, which is yet to complete. We are also thinking of creation of a diabetic nurse, and in the Muse modified early warning signs format, we also thought of including blood sugar level, creation of a standardized patient family education content so that everybody speak the same language and teach back from the patient will be easy. So these are the few activity posts project we have done. Categorization of insulin as per the types like rapid acting, long acting, and short acting, we have categorized and we have stored. And this is a standardized PFE template which we have created and we are circulating to the patients and family during time of discharge, in even in OPD, even in clinics. And fast forward food tray, especially for diabetic patients, we have talked and discussed with FNB team, and we have make them understand the importance of specific tray for these diabetic patients. So this was also done. I am mentioning about point of care blood glucose tasting glucometer. This is a daily practice which we do to know that quality check of the glucometer is in proper place. So we take the low range and high range of the glucometer and we check every day, and the compliance of the glucometer quality check also being done as a audit purpose. And compliance to blood sugar, it is a daily process. So this is the compliance rate post this project, which is a monthly activity. So this is the compliance which I have mentioned here. uh, it is a very crisp project. However, we have done lots of brainstorming, and that is the reason why we thought to publish this QIP. And Tangam ma'am has helped us a lot, and we have finally published this QIP, implementing a standardized protocol to mitigate hypoglycemia risk and enhance patient safety in hospital settings, which is published in International Journal of patient it is an international journal where it is already published, International Journal of Science and Research. This is the link. If any of you would like to go and visit the site, please go and do it. To summarize, hypoglycemia in healthcare settings are very, very common. I think you all can contribute so much with many examples. It is not so that now we are not facing hypoglycemia, still it is there. And recurrent hypoglycemia, if it is happened, then it is going to be very, very fatal and sentinel events. So it should be considered as one of the high risk process in every healthcare systems. Continuous training, reinforcement, and following standardized protocol will definitely help in avoidable patient harm. And this need to be understand very, very in-depth manner, that why hypoglycemia need to be prevented. These were my reference. Maximum references were from Patient Safety Foundation, Movement Foundation, Severe Hypoglycemia, and American Diabetic Association as well. So as ma'am has already mentioned, upcoming, because I'm from Northeast chapter, and it is again proud moment for me that we are hosting fifth annual patient safety conference. So I urge everyone to come forward and register when seats are available already, and you can also submit your quality improvement projects for, it is going to be, this is only released today. Thank you so much. I would like to stop here, and I would like to hear from the participants where you identify some hypoglycemia events and how do you manage in your hospital, or is it something similar we do, or if anything new which we can also implement and we can take forward.
Thank you, Karishma. You can stop sharing. Mm. So I'll start with couple of questions to you for the sake of, participants sitting here. If you can tell me that before you started the project, you were not having glucon D, right? Yeah.
Yes.
And were you keeping glucose sachet, sugar sachet? Were you keeping? No, that
No,
was off.
ma'am, that glucon D packet.
Okay. So glucon D packet is what you have kept, right? And you have got standardized protocol. How much of glucon D to be given? 1 tablespoon, 2 tablespoon. What is that protocol? If you can tell them.
Yes, ma'am. It was 2 tablespoon. I think it is not visible properly. That hypoglycemia algorithm which we have created and that is approved from DTC committee, where reference is American Diabetes Association, and it is already mentioned if patient can swallow or patient doesn't have a IV cannula, what to do. If patient have a IV cannula, what to do, and if patient can swallow, then 2 spoon, or how to do that, make a paste and put in the gum. So this is clearly mentioned in the algorithm which nurses can easily refer and they can use it.
So, after you started this algorithm, did you have hypoglycemias which actually needed IV glucose?
Yes, ma'am.
And what
Yes, ma'am.
percentage do you give?
Ma'am, 25% dextrose.
So I have a very big question around this because it always keep bothering me. If you give 25% dextrose, which is very high osmolarity in a peripheral IV, one is that it will definitely damage the vein.
PIVC line.
Peripheral IV, it will definitely damage the vein. And the other thing is, it also kind of indicates our failure to identify hypoglycemia early.
Yes, ma'am.
Or that
True.
leads to the patient being unconscious, and then you resort to IV only when patient cannot take something orally. Correct? That is what is in your algorithm. So I would like to hear
Yes.
from the participants also sitting here. Why is that 25% dextrose is being used? Is it mentioned somewhere, or I don't see there is any literature evidence which says that you give 25% dextrose. Why not give 10% dextrose?
Ma'am, as per the blood sugar level, like it is, even I did not see any literature when I was even preparing this QIP. Sometime we start 10% dextrose as well, but majority time, I think because of its convenience or because we want to treat the patient as fast as, so majority of the time 25% dextrose goes, but there is no literature.
Yeah. So, do you think there is a need to deep dive into these 25% dextrose patients? Why did we have to resort to 25%? Is it
Mhm.
really a need? Because I have a feeling in my personal experience, we tend to go by numbers, the blood sugar
Mhm.
number, without even looking at the patient's condition.
Sign and symptoms, correct.
So it's very important to look at the patient and see that how is the patient with that number blood sugar? What was his previous blood sugar? There is also a danger that you will give 25 and you will spike the blood sugar very high. Though that very
Mhm.
high blood sugar will not kill the patient, but hypoglycemia can definitely damage the brain faster. We understand that. But I think this entire project is about also doing the right thing for the patient, right?
Yes, ma'am.
So, what did your
Ma'am,
doctor say?
patient
They,
also exhibits different signs as per, like some patient will sweat. Recently we have seen one patient, limbs became very cold, only limbs, otherwise nothing was done. Then immediately we have checked the sugar level, and it was hypoglycemia. Then so patient also exhibits as per their, it is like different sign and symptoms they
so
exhibit.
I
So it
still
is.
have the question, why 25% dextrose when there is no literature guidelines to give 25% dextrose? So I'm putting it out to all the people to see that there is another reason to do
Need
continue
of.
another project to see that why we are ending up giving 25% dextrose. 10% dextrose I can still imagine, but if you give that, if the patient does not have a central line and you give peripherally a 25% dextrose, it's very high osmolarity. It will definitely harm the vein. So I would like to hear that, from the audience, what are your thoughts? What do you give in your hospital? Do you give 25% dextrose or do you keep glucon D? You keep sugar sachet? What is your protocol? Or do you have an algorithm or you don't have? Can we ask some, members from hospital to share your experience?
Yeah, please, we want to hear because this project was only for a few months and we have closed it. But again, it is very, very important, as ma'am said, to dive into the deep dive actually to know more and explore.
We have time, so we can definitely explore a little in depth about this. Meanwhile, I have couple of stories to tell around diabetes. I'll come to that later, only when somebody answers this question. What are your protocols around managing hypoglycemia? So, what was the percentage reduction, Karishma?
Ma'am, hypoglycemia, it was 38, ma'am, when we have done the pre uh, pre-implementation. Post, it was 8 hypoglycemia events.
Okay.
And other that compliance to, like the food timing and the administration of insulin, those were also we have audited during the time. And the storage of insulin, the awareness of types of insulin, those were also our audit point.
Okay. There is a question here. What procedure you follow to customize the type of insulin? I don't understand the question exactly. Dr. Geeta is
Types of
customizing the types of insulin. That is usually the job of a doctor.
Yes.
Nurses do not customize insulin, right? And they may follow the sliding scale if their patient is on regular insulin. They usually don't give anything else, correct? Am I right? Yeah.
Yes. Yes, correct.
So they want to see the standardized protocol for identification of hypoglycemia.
Okay, I'll send it in the chat box, ma'am.
Yeah, yeah, please do that. You can share the link of your article also with study that is
Sure, ma'am.
published.
Sure. I have done, like little detail about hypoglycemia as a session last year, any our session. So that also, if we can go to any YouTube, and that will be there. So it was in detail from Patient Safety Movement Foundation reference.
Okay.
Last year there was a content.
Okay. So I asked ChatGPT something. I'm very fond of
Okay.
ChatGPT to understand, they give very quick answers. So I said, what is the algorithm for managing hypoglycemia as per established guidelines? So this talks about American Diabetes Association, International Hypoglycemia Study Group, Endocrine Society, and Indian National Guidelines. So from there, what it is saying, there are three levels of hypoglycemia. Level 1, where the blood sugar is less than 70 and more than 54. This is called
Yes.
the alert level. Level 2 is less than 54, which is clinically significant. Karishma, if you can mute when I'm talking, I think there is an echo with your system. If you mute, I think that's better. Level 3, severe event characterized by altered mental physical status requiring assistance, that is medical emergency. So those who want to create, maybe you also might have defined hypoglycemia definitions. The algorithm is first is recognize whether the patient is having what symptoms. Mild to moderate when patient has sugar less, sweating, shakiness, hunger, irritability, palpitations. Severe will be, of course, confusion, drowsiness, unconsciousness, seizures. So you immediately check the blood sugar, proceed with treatment. So let's see. Conscious and able to swallow. That is level 1 and level 2. That means blood sugar above 54. I hope all of you are listening. Uh, this is actually science, from the international bodies. Use the 15-15 rule. It is called the 15-15 rule, and it says 15 gram of fast acting carbohydrate. So I think abroad they have got glucose tablets. So they are giving 3 to 4 glucose tablets or you can give 120 ml of fruit juice or regular, soda, non-diet, or 1 tablespoon of sugar or honey. So this is the 15 gram of fast-acting carbohydrate. Then they are saying wait for 15 minutes. That's why it is called 15-15 rule. Then recheck blood sugar, and if it is still less than 70, repeat the same. After recovery, give a long acting carbohydrate with protein snack. That means whole bread with peanut butter or honey you can give so that the blood sugar comes up. And if the patient is unconscious, so let's see what does level 3, the recommendation from international bodies. Do not give oral intake. That is one, of course. And here it is talking about glucagon injection, which is not usually done in hospital. This is only done in rare conditions, or IV 25 to 50 ml or D50 they are talking about. So there is reference of not 20, it is actually D50. Now I don't know about which IV access. Place patient in recovery position, call for emergency services. After recovery, you check for glucose in 15 to 30 minutes until stable. Then, of course, the rest of the thing, I'm sure that, uh, all of us are knowing. So, this is what I could find now. So, I'm going to ask one more question to ChatGPT. Till then, I want you people to opine what is your hospital's protocol? Do you have a protocol? You don't have a protocol. Hello? We have 173 people in the session. That is a big number. And if we don't have one or two people speaking, then it is sad. Yes. Hello. Hello, friends. Everybody is keeping quiet. Are they behind the logged in place, or they have logged in and they have gone somewhere else? Yeah. Hello. Nobody is asking any question. Nobody's. Yes, we have protocol in Fortis Jaipur. Okay, at least some people are answering now.
Texting.
We too use 25% dextrose. Okay.
Ma'am, may
Yes.
I ask one question, ma'am?
Yes, yes, yes.
Yes, ma'am. Ma'am, as I think maximum hospitals they are following this 25% dextrose to give immediately when there is an episode of hypoglycemia. That is also we are following as per the protocol. But ma'am, as you mentioned that we have to give the calorie in the first 15 minutes. So if there is not available of a juice like a 100 ml juice, somebody has written that as per their hospital
Can give
protocol.
this Glucon D, no? Keep Glucon D everywhere.
Ma'am, Glucon D we can give, ma'am, but the thing is again, the question is if the patient is a known case of diabetic, we can take the measures. But if a patient is a non-diabetic and there is an episode of hypoglycemia, it is related to the disease process. So can we follow the same protocol?
Give me an example.
Ma'am, if a patient is a post procedure, the patient got a hypoglycemia because of any reasons. So can we go
What
for this?
post procedure?
Any kind of memo operations the patient is getting, and in between the patient will get a.
Different patients. See, I'll tell you. I am a pre-diabetic.
Yes,
Okay.
ma'am.
I'm telling you my story. I'm a pre-diabetic. So when my sugar went to 110 or 115 fasting, the doctor started me on our basic medicine. What is that tablet? Very common. I'm forgetting the name. Anti-diabetic
Metformin.
metformin. Yeah.
Metformin.
She started 500 milligram. I took 1 day tablet. Next day, I thought I am going to faint. I checked my blood sugar. It was 80. I immediately took something, I drank something, or I ate something so that I became all right. So it was proven in my case that I cannot stand metformin, and I am hypoglycemic when my sugar hits 80. forget about 70, forget about 54. I think I'll be totally knocked out. So why I'm telling this story, that numbers are very patient specific. So it is
Okay.
very critical to look at the, conscious level of patient.
Right, right.
If it is post procedure also, if sugar is down, if patient can drink, why not give them, the sugar? Why do we have to give? So I asked again, D25, D50 peripheral IV. So they are saying ki don't give, you can only give it through a large bore way. And D50 osmolarity is 2525. It is like crazily high. And D25 is almost half the thing. So osmolarity is lower, so it can be tolerated peripherally, but still you have to give in a extra larger vein, if it is possible to give it through a larger vein. And extravasation, if it occurs when you're giving concentrated sugar, stop the infusion immediately, like any other extravasation. Keep the cannula in place, do not remove. Aspirate any residual fluid, elevate the limb, apply warm compress, and then after that there is a recommendation for, hyalo, hyalo, hyaluronidase. I think I have seen it only once being applied, if it is, So this is what the nurse protocol sheet or pocket card you can make. That's not a problem. So these are some things that needs to be kept in mind. Somewhere I think it has gone into our head, or even doctors or nurses are not asking question. Anyone who goes into hypoglycemia, give IV. And I think Karishma's, quality improvement project was to reduce that, correct? So maybe you should not stop doing the project. You should continue. You should use it as an internal quality indicator, nursing sensitive, and continue to see what are the number of episodes of, hypoglycemia. How many of them are being given IV and how many of them are being given oral? I think a quality improvement in nursing process will be, you can avoid any patients who requires IV glucose. That means you are able to catch the patient much ahead of time, because the root cause may be that the patient did not have his breakfast and no one knows about it. It has happened many times when I was in Fortis. The patient around 11 a.m., is like feeling whooshy, and then the sugar is down. Then we are giving oral sugar. We used to keep sugar sachet in all the units. So they will give, one sachet that's almost 1 tablespoon. And Glucon D is better. I have not used it because it is very powdered form. So as you said, you can even put it just inside the mouth. It will just melt, not like the sugar. So when we used to do deep dive, we used to find morning breakfast came, the nurse gave the insulin, then the patient decided, I don't want to eat. And sometimes the attendant ate the breakfast also. The tray also goes empty. You don't even know who had. And our nurses did not bother to go back and ask, did you take your full breakfast? Half, full, what it is. So 11 a.m., when the patient experiences the hypoglycemia, that is the time when we start asking, doctor will ask ki sister pucho breakfast khaya ki nahi. Then the why am I Samsung SMY, your video is constantly on, please make sure that you have your uh, video put off, when you are joining. Okay. So we had to go back to the drawing table, actually train our nurses. It's very important to pay attention to the patient's eating habits, and also to remember the patient hypoglycemia number. Though you have an algorithm which talks about less than 54, 70, but in a patient like me, I am totally out if I am 70, because I know even at home, I know whenever I felt that I could be having low, I checked my sugar with glucometer. Every time it is 79, 80, 79, 80. It is almost like my brain is, starving for sugar. So now all of us know that brain is our one organ that consumes maximum energy. Whatever that we eat, brain consumes because all the time our brain is active. Just like your brain is active now. Okay. So somebody has shared something. Acha, what is that? Is that what is this? This is your article. Yeah. We have a hypoglycemia algorithm. If patient is conscious, non-diabetic, we prefer glucon D, okay, and sugar sachet, sugar less than 70, and check after 15 minutes as per protocol. And for unconscious, we prefer 25% dextrose to prevent from hypoglycemic shock. Check every 15 minutes. I think that is pretty much the current protocol. And I also want to ask any question. Give 25% dextrose peripherally. Have you observed any phlebitis, IV related complications, or or maybe we did not track that? It's a good thing to notice, no? Do we get 25% ampules? Do we get 25% ampules in India now?
Ma'am, we get the saline, that 100 ml one. We
Yeah, so
don't
you
get the
get
ampoules.
25%, 100, and you take from there. You take from there. Okay, okay.
Yes.
Okay. This is last year learning session. Acha, you gave the yes. Somebody is answering yes, phlebitis. So, I think the learning from this entire session, I would summarize is that the nurses should be trained to identify and prevent rather than treat. People should know how to, look after the patients who have a potential for hypoglycemia. And there is lot more that we can do if anybody wants to do more deep dive into this. I'm very sure that there are many aspects of this. So I thought I'll tell you a couple of stories. One is about another fellow had done Amita had done a project about preventing hypoglycemia outside the hospital. That was also a good project. So I had told that story then. I also talk about patient going into hypoglycemia when patients are on insulin infusion. Do you have patients on insulin infusion? Yes. So, and insulin infusion that is also given outside ICU also, correct? Yes, it is not only given inside the ICU, it is given outside. And insulin is an high alert medication, and insulin is one of the most common medication that is associated with patient harm. So, yeah, so they are saying 25% dextrone has high osmolarity, causes phlebitis. So everybody is agreeing that there is phlebitis that is coming up. Then why is it that we are not trying to find out why they are getting phlebitis? So there are, the pros and cons of using 25% dextrose. So there is another project waiting to be done to see that can we actually focus on identifying the patient so that they don't need to get IV dextrose. In foreign, when I worked, I think in India I have not seen that. We used to get 10% dextrose. Do you get 10% dextrose? Do you get 10% dextrose? What is the dose of 25% dextrose when a patient is hypoglycemic? Anyone? What is the dose? How much of 25% dextrose do you give? And you check sugar, 50 ml, somebody is telling. That what you give, 50 ml? Karishma, your protocol is also 50 ml?
Ma'am, it is 100 ml also they give.
25% dextrose, they give 100 ml. Okay. So some are saying 50 ml, some are saying 100 ml. It's very interesting to know that what happens if a patient's blood sugar is, let's say, 60 or 70, and how much does it go up after you give 50 ml or 100 ml? See, I'm asking so many questions. All of them are waiting for answers. And you all have these answers. If you track all this, you can publish 10 papers. Many aspects of the same problem, and you are addressing the same problem, you already have an algorithm. You can now go and do more and publish more to see what is the shift. Do we actually need to give 50 ml, or do we actually need to give 100 ml, or we are just giving and saying, okay, from 70, it will get pumped up to whatever, sugar, because I don't have that figure in my head. Because I know when I was a bedside nurse in critical care, we always had central lines. So 25%, we used to give 10% dextrose. We used to get smaller bottles. We used to get 10% dextrose. And we were very careful that how much of blood sugar are we raising it to. Otherwise, it will become a seesaw, no? You will hold the insulin, the sugar goes up. So it would definitely need, a little bit deep diving from smart nurses like all of you to see that, how much the blood sugar goes up. Okay. So I have asked a lot of questions, and I thank you for giving those answers. Any other questions that come to your mind?
Ma'am, I would like to mention here, like, why glucon D, why not sugar sachet, or why not fruit juice? So there are types of, like sugar, which while preparing for severe hypoglycemia learning session, I have gone through. So fructose, sucrose, and glucose. So it depends on the absorption, as ma'am also mentioned. So it is always the first preference is always glucose, that is glucon D, which it get absorbed. And even if we give fructose, like fruit juice or any fruits or some sweets, it will take time to dissolve and that
A
treat the
slightly
hypoglycemia.
complex carbohydrate. So the
Yes,
simplest form is,
yes,
sugar. Yeah.
sugar. So that's what I would like to
I think
mention.
glucon D is
And
easy
10%
available.
dextrose we get as a 500 ml, like bigger one. So they used to give like some ml per hour, so it goes on for some hypoglycemia. So otherwise it is not mentioned 10% dextrose how much to give in the hypoglycemia protocol.
Okay.
So we
So there
really
are a
need
lot,
to
of
take
questions. There are a
those
lot
one.
of questions. There are a lot of questions that can be answered. So if you have a data collection sheet, which you capture all these things, the, like you did the previous project, that what is the patient condition, what was he getting for controlling the sugar, under what condition he got the hypoglycemia, what did you give, what was the first 15 minutes sugar after you gave, was there a second intervention, then what was the maximum sugar that was reached in the first hour, and how much time it took for the patient to come back to his, kind of his pre-hypoglycemic sugar, unless you track all of this, probably we will not know the real story. So now glucon D is something that I have not tried when I was in the hospital, and I think it's a brilliant idea because it's a very simple sugar, because the other sugar is not powdered, no? That is also simple, but it is not powdered. So you cannot give it to someone to have it because it is granules, right? It will take time for it to melt, though it is also simple sugar. So maybe glucon D is a good option. And maybe you should write the glucon D company that they should make sachet for hospital, isn't it? Then you don't even have to worry about 1 tablespoon. So
Bigger,
these are
yes.
the kind of things, nurses should take charge, and you can write to the glucon D company. Why not? Because their sales will increase like anything. Every hospital will buy then sachet. Because this what happens if there is air goes into glucon D. I have seen
Mm,
it gets clumped. And they are big packets, and you have to
big
charge.
packets.
Either you
When
will
it
give.
get expired, it is very difficult.
So
Some
you
unit
don't
it get
know.
expired without utilizing.
So I think we should write to the Glucon D company that we would like you to prepare and produce sachet. I'm sure, just like sugar free, they are making sachet. Sugar free, they have sachet. Diabetic patients to put sugar, sugar free, powder. They make sachet. I'm sure they can also make Glucon D sachet. Good idea. So I think I'm also going to see that whether I can get some connection to Glucon-D and give this feedback to them. Do you think all
Ma'am,
of
one
you
more thing I would add, one more thing I would like to add. In the diabetic certification course training, we have also added because we have found that breakfast, that plate was not getting empty, then insulin was given. So we made things like we have to really see the plate, how much 1/4 or 2/4, what patient actually consumed and what is not consumed, and it has to be communicated to the treating consultant so that we can play with the insulin dose. If, as you rightly said, patient did not have anything, and if we do not consider that at all and administer the insulin, patient will definitely go to hypoglycemia. So that
so
nutritional note is
yes,
also
you
very, very
see,
important,
this is
but we need
yeah.
to work more on that.
I think that's the coronary care unit I worked when I was abroad. We actually discussed with the diabetologist and the intensivist, and shifted giving the insulin halfway through the breakfast, not before.
Mm.
So that way we were sure the patient is eating, because we had problems where we gave insulin and the patient decided not to eat, right? So I think there's a lot of things that can be considered, and keep and write, study, write about the experience. That's how more questions will come. That's how we can create our own evidence also. That's good. And Karishma, thank you so much. I don't think anybody else is asking any questions, so I would like to wrap up now, to also make sure Karishma is free and not sitting in one position for a long time. So thank you so much, Karishma, and take care. And thank you everyone for being here. When I was in army, we used to give 50% dextrose during hypoglycemia, and a maintenance dose of 5% dextrose infusion was given. I think that directly giving that is now outdated. There is no recommendation for that. Unless your patient is unconscious, there is no IV dextrose recommended by any of the international bodies. That's the summary of it. So thank you so much, everyone. And you still have questions, you would like to do some project around something, please do feel free to contact any one of us, and we would like to help you. Thank you, everyone. And please register and join us for the annual
Patient
ANEI Patient
safety.
Safety Conference at Guwahati. It is at All India Institute of Medical Sciences, Guwahati. See you all, and Sabha Khair. We will see you
Thank
next
you
month.
so much, ma'am. Good night, and thank you to all for joining in huge number and contributing so much. Thank you so much.
Thanks, dear.
Good
Take
night,
care.
ma'am.
Good night.